Dr. Kalra, thank you so much for joining me today.
My pleasure, Sarah. Thank you for having me.
Oh, well, listen, I'm thrilled to have you here. And today we're discussing a topic, an incredibly emotive topic, miscarriage.
That's right.
I've got quite a lot of questions for you that so many people desperately need the answers to. But first of all, could you just start by explaining to me what is happening to the body when it's having a miscarriage? What exactly is miscarriage?
Right. So miscarriage is a condition or a situation when a woman who's pregnant is losing the pregnancy. The pregnancy is coming to an end. And the consequences or what happens are from immediate to long term, eventually can be, and that depends on the stage of pregnancy, the duration of pregnancy, how far the pregnancy is gone. It affects the woman straight away physically. Most often it will affect them physically, and the physical impact will be again depending upon how far the pregnancy is gone and how much the body has to deal with, because quite a lot of, in fact, most of the losses happen very early on. A lot of times women will not even know that this has happened. These are pregnancies that have not yet been recognized. They're too early. And we'll come back to that. Now, if they know they are pregnant and it is very early on within the first trimester, first 6 weeks, 7 weeks, they will have physical signs and symptoms like bleeding, pain, cramps. So a lot of hormonal changes happening. There is a lot of pregnancy-related hormones around in the body. They sort of start to go in a bit of a disarray, and that causes emotional disturbances as well. But also there is a whole area that, you know, there's a big impact on women psychologically. So there's a physical effect when it is happening, and there's a psychological effect when this is happening. The physical effect probably lasts not as long as the psychological lasts, and potentially can last. Somebody has put it very well. I was reading it. I think it was probably on one of these information websites I read. Tommy's, for example, that's in the UK, isn't it? Tommy's UK, which gives information to women. I think it was Tommy's, no, Miscarriage Association. That's another very good one. And it says that a woman who's lost a pregnancy has lost a pregnancy. If she was not able to hold the baby in her arms, that does not make it any less traumatic. She's lost the baby, whether it is 5 weeks, 10 weeks, 30 weeks, or after birth. It's difficult sometimes for other people to understand that, but it is a loss, and it's a horrible situation for that woman to go through, very painful times psychologically as well. So what I want to stress on a little.
Yeah. Yes. Well, I suppose the question is, why does it happen?
Right. So there are several different causes that it can happen because of, but the understanding so far scientifically is that most miscarriages happen for genetic reasons. There are chromosomal or genetic abnormalities in these conceptions, and they are not viable. So it is a way the body kind of ends those non-viable or unhealthy or pregnancies that are going to have major problems eventually. So they're not compatible with life. But the woman who has it does not know that, understand that there is not that much wrong with it. So most of these are because of genetic abnormalities. In fact, some studies have suggested that it's up to 80%, 90% of miscarriages are because of genetic abnormalities. A lot more before 10 weeks of pregnancy. The sooner, the more genetic involved. There are other reasons for miscarriages to happen. For example, there can be immunogenetic causes. Things like autoimmune conditions. Like one of the major contributors to miscarriages is women who have what we call antiphospholipid syndrome, which involves development of some hostile antibodies like anti-cardiolipin antibody. It's a little sort of scientific to be going into here. Anti-cardiolipin antibodies, lupus anticoagulant. Lupus is more commonly known. There are a few more antibodies. So antibodies that body starts developing towards its own self, kind of. They're autoantibodies, and they can lead to miscarriage. The risk of miscarriage with these women is quite high. Then there can be reasons like abnormalities in the womb anatomically. The shape of the womb by birth can be abnormal. There can be split womb. There can be two cavities in the womb. There can be, for example, septum, different so on and so forth, different things. And that seems to be associated with miscarriages. There is what we call thrombophilia, predilection to make clots more readily, the blood clots more readily. And these are the women who are also prone to get DVTs, etc., the clots in the legs and lungs, which are a risk to their life and health. But this also forms sometimes microthrombi in the placental bed, for example. Placenta has, as it is growing in very early stages, this vascularization, the development of the blood vessels that's happening is at a micro level. The development of blood vessels happening, and very small clots can block them. So the microthrombi can develop in these conditions, and that can stop the blood flow and therefore lead to damage to the embryo or fetus or baby. There is other sort of hormonal reasons, like women who have thyroid problems are more prone to miscarriages. That affects indirectly through hormones. So even PCOS is sometimes associated with it, although the evidence is not the strongest. But yes, people commonly believe that PCOS can lead to it. There is also this thing about endometrium. Endometrium is a very complex organ. The lining of the womb is an extremely complex, sophisticated organ. It has a job to select the embryos. So embryo and endometrium talk together. There's a dialogue going on, and embryo signals to the endometrium. Endometrium susses out the embryo, and if the embryo is abnormal, the endometrium rejects it. Or it may start implanting and then reject it, what we call an early or biochemical pregnancy. And sometimes embryo manages to. So sometimes what happens is that endometrium is too receptive. Sort of uncritically receptive, even the abnormal embryos will settle. Mm-hmm. But eventually, those embryos are abnormal and genetically not viable with life. So they end up in miscarriage because they can't go any further, right, while endometrium has accepted them. Sometimes the endometrium is too selective. So it's too receptive to too selective, the spectrum. Sometimes it's too selective. It's so selective that it even rejects the normal embryos or pregnancy. So there's a whole raft of reasons that can lead to miscarriages.
But for a woman, for any woman, miscarriage is devastating.
Absolutely.
But even more so for a woman who has really struggled to conceive and who has gone through, and paid, money for an IVF round to then miscarry, because for a lot of women, funds might have ended there, so it's a huge loss, because what do they do? For those that can perhaps go for another round of IVF, do you then, do you do tests at that point to find out why there was a miscarriage, or do you have to wait? I've heard some clinics wait until a woman has had 3 miscarriages before they then start testing. Is that
yes,
what
happened? So, as I said, miscarriages are extremely common if you look at that. And it seems that more pregnancies, more conceptions that happen, they end up in loss than those who go through to become successful live births. If you look at the total numbers, and if you include all those pregnancies that were never even recognized, for example, they happened so early that a period was a day or 2 late, or not even late, maybe 4 days. So quite often, as a gynecologist, I hear that last period was 2 days late. Women don't take that like, could have been pregnant. And a lot of these are because they've been pregnant and they just are losing pregnancy, and therefore the period is delayed. So sometimes it is not even delayed, and if you take all the unrecognized pregnancies into account, then up to 70% of pregnancies end up in miscarriage.
Wow.
Nearly 30% of those will be those who haven't even implanted. 30% will be post-implantation, that they implanted and then rejected. And 10% will be those who managed to go further than that and then miscarried. So as we call the recognized miscarriages. We know that if you look at only recognized miscarriages, it's about 1 in 6 of all pregnancies, about 15%, 10 to 15%. That's what kind of number we're looking at. So a lot of miscarriages happening, okay? And those that then carry on further than that, they become live births and successful pregnancies, as we call them. And you ask at what stage we start investigating it. So they're so frequent that the investigation is not the first thing you do when there is a miscarriage, depending upon their history. Traditionally, if it is happening repeatedly, it has been called, what it's called is a recurrent pregnancy loss. Okay, and most professional organizations or science has looked at 3 pregnancy losses as a cutoff where we start investigating, and there is a reason for that. That from 3 pregnancies onwards, there seems to be a significant increase in risk of subsequent pregnancy loss for every further pregnancy. The risk increases every month. Up to 3, the risk doesn't increase that much. But now, currently, not in the last 2 or 4 or 5 years, some organizations have started moving towards calling 2 losses as a recurrent pregnancy loss. They start investigating after 2 losses. Having said that, it is also scientifically evident that even out of the recurrent pregnancy losses, there is half that are true recurrent pregnancy losses and half that are sporadic recurrent pregnancy losses, and nearly 60-70% of those are again genetic, because it is it's something like where you cannot identify a cause in the parent. Those where you will not be able, and those you will not be able to do much unless so you don't find a specific cause, and then you analyze the conception, you find out, and the majority of those are sometimes 80-85% have been quoted to be because of genetic causes. But about 50% you will, if you look hard enough and look for everything, then you might find a cause.
Does PGS testing, could that help? Would that,
right?
Would that help with
So that question is the $1 million question, because it's probably one of the commonest questions talked about or asked in IVF circles, because PGS is gained ground. PGS, which we now call PGT, pre-implantation genetic testing, which we used to call screening in the past, or pre-implantation genetic diagnosis for specific genetic issues. It has its role in selective circumstances or situations. It isn't an umbrella answer to miscarriages. Now, we know that some of the miscarriages are happening because of genetic abnormalities or known genetic abnormalities. For example, you can have parents who are carrying a genetic issue, which can go down to the conception, and then you can do something called PGT monogenic, that you're looking at a certain gene. You can test for that, and you can avoid putting that back. You can have parents who have translocations, which leads to structural rearrangements in the conceptions, which lead to increased risk of miscarriages. And some of the recurrent pregnancy losses, say 2 to 8% in quoted in literature, is because of structural rearrangements. And those you can test by doing PGS and PGT, which is PGT-SR, PGT structural rearrangement. And then you can avoid putting those back, because those are not viable with life, a lot of them. And then you can do PGT aneuploidy. And a lot of these genetic changes are, again, sporadic. In the process of fertilization, they happen. They're de novo. They're not coming from the parents. And most of those are trisomies. that the chromosomes did not manage to split equally, and therefore you get an extra set of a certain chromosome, etc., etc. Something like trisomy 21, which is Downs, which quite often is viable with life, and Downs babies we have around, lovely healthy babies, not as healthy, but that is viable with life. These, if we start screening the embryos, then we can identify those kind of abnormalities, and then one has a choice not to put those back. And what it helps with PGT, I would say overall, is so if you have 5 embryos created through IVF, and you don't test them, and some of them are going to be abnormal also, and it is a very clear idea we have that based on women's age, the risk of these abnormalities, what we call aneuploidies, increases. For example, around 38 to 40, 80% of them, sometimes 70, 80% of embryos can be abnormal. And when you test it, you do not put back the abnormal ones. And therefore, you are minimizing the risk of miscarriages and the heartbreak and the trauma, the physical as well as the psychological. So that is something big for some women who have repeatedly those situations. Also, by putting back the healthiest embryo, genetically normal embryo, you're potentially bringing close the time to pregnancy, a successful pregnancy. Mm-hmm. This is the main advantage I see, and is more useful in women who are plus 35, generally, I would say, unless there's a known problem in younger women or partners. Mm. So that's where PGT is placed at the moment. Of course, the opinions can be different among scientists and doctors. Some believe, yes, it is the answer to a lot of genetic related miscarriages. Some think it hasn't got much of a place. But this is my view around PGT.
A lot of women that I've spoken to, and in fact, their partners as well, they've automatically gone to blame themselves when a miscarriage has happened. And
automatically gone to do what? Sorry, my apologies.
To blame themselves for the miscarriage. Yeah. And in fact, I was talking to a brilliant man who blamed himself for the miscarriage because he said, "Oh my God, I asked my wife to carry the heavy shopping from the car. Did I cause that miscarriage to happen?" So I think there's always that element of what did I do wrong?
Yeah, you're right. Yes, I see that not infrequently. So this is a known response to the trauma of a miscarriage. The way it generally happens is the first response when they find out they've had a bleeding and somebody mentions you may have lost it, or by scan says, "I think there isn't anything there, I'm sorry," or "we need to do another scan because I'm not sure." That leads to a lot of confusion. Confusion is the first response. They get very confused and they're very scared. They get fearful. Fear is immediate. Then there is, once the diagnosis is made, there is shock. It's, as I said earlier, whether it is 5 weeks, 10 weeks, 20 weeks, 30 weeks, that's a baby that they were going to have. For that mother, that couple, that's their baby that they were going to have. So that is shock, pain, grief, the whole grief response they go through, grief reaction they go through, guilt is a part of it. They feel guilt. And then the anxiety for any further pregnancy, massive anxiety. Yeah. It is said that about 40% will have anxiety, which can last long. Nearly 40, some papers quote 50% incidence of post-traumatic stress disorder, like of anxiety, like of syndrome. About 15% can become depressed, on an average lasting about 4 to 6 months, sometimes longer. So there is a huge, complex psychological impact on these women as well as. Again, some people describe it that as it isn't any less than a loss of a family member to them.
Yeah.
Or a trauma of separation, etc. It is a big psychological trauma to these women and couples.
Yes. And so so I think, because a lot of women also say, is there anything I can do next time just to make sure? So there's nothing a woman can do. It's going to happen. It's going to happen. Or is there anything you can do yourself to lower the risk?
Yes, I think you can. I think you can, if not a lot. So first of all, somebody to explain to them. I think there is a lot of literature out there. I think these two websites I mentioned earlier, because I was used to referring patients to them, Tommy's and Miscarriage Association are really good. There's a lot of information. But somebody sitting with them and explaining to them in this way that this is why it is very common. It isn't something you've done wrong. X amount of pregnancies end and X amount end because of genetic abnormalities, which you have no role in. Generally, most likely no role in. So reassuring and counseling and guidance around what's happened. That's one thing that makes them feel a little bit less agitated. The second thing is, and then being there for them to come back to if they have any more need to talk.
Yes.
And the second thing is there are some lifestyle factors as well that increase the risk of miscarriages one can talk about. For example, we know that obesity, we know there is evidence that women who have a BMI starting from 25 and above, but certainly 30 and above, there is increased risk of miscarriages. Alcohol, although we have said that a glass of wine is fine and so on and so forth, but there are papers suggesting that any amount of alcohol increases risk of miscarriages, even so little to so much, depending on how much alcohol intake is there in pregnancy. Smoking, not so much early. The evidence is that smoking leads to impact the growth of the baby in health and the risk of stillbirths and growth retardation in later. So late pregnancy loss is smoking. There are these things which one can counsel them around. If there is any of these risk factors present, then one can improve their lifestyle. Apart from that, I think, as I said, the miscarriage is so common that the structured formal investigation is generally not started until nowadays two pregnancy losses, where they start calling them recurrent pregnancy loss, or three sometimes, to start systematically investigating for all the causes I mentioned earlier.
Yes. Can I just briefly go back on to something you said earlier about the signs that you are miscarrying? Because a lot of women during the early stages of pregnancy, they do bleed, don't they, or spot? I know I did. And of course, my first thought was, oh my God, is this a miscarriage? Why do some women spot, but it's not, leading to a miscarriage? What's happening there?
Right. So there is a variation in how it presents. Sometimes there will be no symptoms. They will go for a scan, and it will be a chance finding that the fetus hasn't grown, the baby hasn't grown from a certain stage, that there is not a live pregnancy in there. Sometimes they will have bleeding, spotting. Now, spotting and bleeding is a lot more common than miscarriages. So a lot of those spotting episodes are not because of miscarriage. There can be other reasons to it. But all those will be considered as a part of threatened miscarriage or imminent pregnancy loss. And one grades it from depending upon the severity of the symptoms. But, so it is, as I said, some of those are not at all pregnancy loss related. Some of them are just a start because pregnancy is failing and the hormones are dropping or changing, that there is some decidual reaction, as we call it, the lining of the womb, which is now pregnancy supporting lining, decidua, that starts coming off little by little, and then initially you will have some spotting or small bleeds until it becomes a problem. It's just like period starts, in a way.
But is it true sometimes you might not be losing your baby if you're spotting?
Absolutely, as I said, sometimes you may not have any bleeding at all.
Yes, yeah.
Sometimes you'll have spotting. Sometimes you'll have heavy bleed with cramps and clots and passing the products. But one thing I'll mention here, which is important to note, that some of these pregnancy losses are ectopic pregnancies, and that's important to be mindful of for the patients as well as doctors. And that should be in their mind, that if a bleeding is happening, one has to rule out ectopic pregnancy. Therefore, the scan at the appropriate stage is so important. If not, then beta HCG, the blood test of pregnancy hormone, and there are some ways to making a judgment on that if it is not rising to a certain degree, or if there's a past history of problem with the tubes, or if there's a past history of ectopic.
What is happening? what is, can you just clarify what the ectopic is?
Okay, sorry, I should have done that. So ectopic pregnancy is a pregnancy that is not sitting at the right place. So, you know, when the egg and the sperm meet, when the conception first happens, it happens in the fallopian tube. So the sperm travels through the womb into the tube and down the tube, and the egg comes up the tube and the meat and the tube. So the tube has a very important function here. It's got a vital function. And the tube creates a right environment for them to fertilize. The fertilization happens. The tube, the embryo is created, and as the embryo is growing, it is moving up the tube back again. So that's an active process. The tube sort of moves the embryo back up, and the embryo then, you know, if the tube has got a problem, like it is not healthy, it is scarred, it is not functioning and not doing that job of pushing it back up, then it can get stuck in the tube. And if it gets stuck in the tube, then the pregnancy can settle in the tube for a few weeks. And once it settles in the tube, and tube is of course not an organ to take care of the pregnancy forever. Therefore, after a certain stretch on the tube, it can burst. So that's the risk. Now this is one of the commonest kinds of ectopic pregnancy. Now, ectopic pregnancy can be in an abnormal place within the womb, not in the main area where the pregnancy is to sit, in the neck of the womb, in the tube, in the angle of the tube. It can also be outside the tube. It can be near the ovary, it can be in the abdomen. It has been found many places in the abdomen, you know, rarely. So that's an ectopic pregnancy. It's ectopic, it's outside the right place.
Yes.
And those pregnancies carry high risk because they can bleed heavy. In the past, they have caused loss of life of women. Perhaps in certain less well-managed parts of the world, healthcare-wise, it still happens. So one has to be bearing that in mind, that the incidence of, and it's because the incidence is not that low, nearly 1% or just slightly more than that of all pregnancies, recognized pregnancies, can be ectopic. So 1 in 100, say. Therefore, 1 in 100 women can be at risk of real serious harm. And therefore, one has to bear that in mind. And the doctor has to then kind of do the right investigations to rule that out.
Yes. One thing I have learned since, you know, launching IVF Babel is conception through to live birth is like magic, isn't it? It is so incredible, because there's so much involved and there's so much risk, and you know, life is quite incredible. But I just want to thank you for today. This is, you know, such an emotive topic, and I'm so glad that you mentioned those charities as well, because they offer such huge support. And I'll make sure I list those when I publish this conversation.
Yeah, they're very useful. They've got a lot of good information in them.
Yes, yeah, and also the fact you know, you mentioned those percentages of miscarriage. It's so high. I didn't realize it was that high, actually. But then when I think about it, when I think about friends that I know and women that I've spoke to, there are so many women I know that have had miscarriages, and multiple miscarriages.
That's right. See, it's one of the, so for me it sort of goes through my say the type of patients I see. Is a similar kind of story in IVF. There's a huge psychological burden in IVF, and under-recognized, not talked about, not dealt with. So there's a whole large number of women sitting with a lot of psychological distress there, not being helped as they should be. In a similar situation as with miscarriages. People do not, unless closely related to it and feeling it, do not recognize how damaging it can be, how much impact it can have on people's well-being and life. So for me, it is the whole spectrum has a huge element of psychological dimension to it. And then important to recognize that.
Yes, yeah. But, and I suppose that the one thing to take from this is that it doesn't mean the end, does it?
It doesn't.
It doesn't mean the end. And yes, and so if anybody has any further questions, can they contact you directly at the clinic?
Absolutely. Okay.
Thank you so much for today. It's been so insightful.
Thank you, and you're welcome.